Thank you, sir. So now I would like to request Professor Chintan ma'am to present her talk on swept source ASOCT applications for the anterior segment surgeon.
Thank you, Sonam, and thank you to AIOS APO as well as Dr. Amit for including me in this course. What I'll be speaking about over the next 10-12 minutes is about the swept source OCT and how it can help us in the anterior segment surgeons. If we go to the ASOCT systems, there are different technologies available. We have the time domain, the spectral domain, and the swept source OCTs. Each of these have different properties. What the swept source basically has the advantage over the other two is that it has a much greater scan depth and a scan width as compared to the time domain and the spectral domain. The axial resolution of the swept source is good, although it's a little less than the spectral domain. And it has a very high scan speed, so which makes it easy to capture images even in patients who are somewhat uncooperative, like small children. So these are two images which are showing the picture on the right side of the screen, showing the CASIA 2 OCT, no financial interest, which is a form of swept source OCT, where the depth of the scan is 7 millimeters and the width is 16 millimeters. So there's limbus to limbus coverage. On the other side, we have the spectralis OCT with the anterior segment module, where the scan depth is only 2 millimeters and the width is 6 millimeters. So with the spectral domain, if we want to see, for example, in this picture shown an ICL, we cannot see the cornea. Whereas with the swept source, we can see from the apex of the cornea to the lens. So with the swept source ACT, the cornea and the lens, including the posterior capsule, can be visualized simultaneously. Now, there are multiple purposes for which the swept source OCT can be used. And in fact, I would have to say that, like for even in our department, beyond the cornea surgeons, is the glaucoma surgeons as well as the strabismus surgeons who are using the OCT as much as we are. But I limit myself to the corneal and lenticular applications. So the swept source OCT has brought about a significant change in the management of lenticular disorders because of our ability to see the lens. And I'll just run you through some of these scenarios. For example, in white cataracts, once we have an OCT, we can modify our surgical technique depending on the presence or absence of fluid and the status of the posterior capsule. For example, this cataract, we see that there is no fluid and the posterior capsule is intact. It's a compact nucleus. So we can comfortably go ahead with the single stage forceps or needle cystotome capsulorhexis and not have to worry about the running away of the capsulorhexis. On the other hand, in an intumescent cataract with fluid pockets which are present both anteriorly and posteriorly, it just makes sense to do a needle aspiration prior to initiating the capsulorhexis, which will decrease the risk of an Argentinian flag sign. In traumatic cataracts also, when the lens matter is very flocculent, we can try and see the contour of the posterior capsule. It may not always be visualized. For example, here we can just see a part of the posterior capsule, but the contour can give us some idea whether the PC is intact or not. This is beautifully captured in this image where this patient developed a cataract after receiving intravitreal steroids 1 month later, and we can see the breach in the posterior capsule so beautifully. And this helps us again in planning preoperatively. We know that we are going to need a vitrectomy probably and the type of lens that we want to plan. In traumatic cataracts, the sensitivity of the swept source OCT has been shown to be extremely good. It's close to 97%. And the advantages of a swept source OCT over the UBM are that it's non-contact, so it's safer in cases with repaired scleral wounds. We have better cooperation in children. The only drawback being that structures behind the iris cannot be visualized, which can be seen with a UBM. Then ASOCT is also being used a lot in posterior polar cataracts. For example, in this picture D, which is being seen, we can see that the posterior polar cataract is there, and it's difficult to identify the posterior capsule posterior to the plaque. So this is a grade 3 posterior polar cataract, and here we have it's been shown to have around a 60% risk of a posterior capsular rupture. This is one of our patients. We see that there is a dense plaque of posterior polar cataract, but this falls in grade 2. That is, there is no clearance between the opacity and the posterior capsule, less than 50%, but the posterior capsule is visualized. So the risk of a PCR in this case would be a little less than a grade 3. And post-operatively, we were able to implant the IOL without PC rent, but we can see how flaccid the capsule is. Phakic IOLs, the swept source OCT can be used for ICL sizing software. For example, we have the NK formula and the KS formula, and these can be used, especially in borderline cases where our manual digital caliper where we are measuring, we can correlate with these. Postoperative evaluation of the vault height and the crystalline lens rise. So if the crystalline lens rise is more positive, then we want to go in for an ICL with a higher vault vis-a-vis if the crystalline lens rise is negative. And this is just showing how we can measure the ASOCT vault height. And then the sizing for the ICL vault height and for the sizing for the other eye can then be tailored according to that. This is another interesting scenario. So if we have a white reflex in a patient having undergone cataract surgery, it could be multiple things. It could be a PCO, an after cataract, or it could be something else. And this is where, of course, clinical examination is must, but this is where it helps us. So this is a case of an IOL opacification, where there were deposits on the surface, and the internal part of the IOL is clear. So this needs an explantation and an IOL exchange, and not a yak cap, which somebody otherwise might mistakenly try to do. Another case, if you see a white reflex, this could be capsular back distension behind with fluid collected behind the IOL, and this would probably respond well to a yak cap of the anterior capsular margin. I will not dwell on this, but this is one of the most important uses of swept source OCT. For example, we have the IOL Master 700, these are the swept source OCT based biometers. Apart from giving us the IOL, because they are targeting right from the corneal apex to the macula, we can check the fixation and the lens tilt, and also it measures the posterior cornea. But biometry is a separate subject, and I'll leave that for now. Coming on to the second part of my talk, I'll talk about ASOCT in corneal practice. So ASOCT and swept source is a part of the ASOCT family. So in some situations, it would show more benefits, but otherwise it would be the same as other OCTs. And we can use it for medical management as well as surgical management. I'll just run through a few case scenarios. So for example, this is classic, we know. This is a lesion seen on the cornea. There is a hyperreflective thickened epithelium with abrupt transition on the cornea. So we know that this is almost diagnostic of an OSSN. That being said, it's also useful to monitor the resolution of the disease. For example, in this patient, we gave mitomycin C for 3 cycles. Clinically, it seemed to have resolved almost completely, but we can see that the hyperreflective epithelium was persisting, and so we have residual disease after 3 cycles of mitomycin C. And we proceeded to give an additional 2 months of interferon so that the resolution was complete. These are 2 cases, an 18-year-old male and a 55-year-old lady. We have 2 lesions on the OCT which appear very different from the ones that I showed for the ocular surface squamous neoplasia. Here, both the lesions are homogeneous, they are hyporeflective, and they are subepithelial. The epithelium, in fact, is thin. The borders are smooth for the lesions. And this is the picture which has been classically described for lymphoproliferative disorders of the conjunctiva. Now, lymphoproliferative disorders follow a spectrum from very benign to low-grade malignant and then highly malignant. And so this is what it showed in these patients. The biopsy, the 18-year-old male had a history of vernal keratoconjunctivitis. So this was a benign reactive lymphoid hyperplasia. Whereas the 55-year-old lady, she had a follicular low-grade lymphoma. And this is the picture of that lady. So this lesion, on clinical examination, we could have thought it to be a melanoma, amelanotic melanoma, or a lymphoma. But the OCT is quite suggestive of a lymphoma, and we got a PET scan done for her, and there were hot spots in the periaortic lymph nodes. The second use is the role of ASOCT for microbial keratitis. Now, various patterns have been described. You could have inflammatory plaques on the epithelium, the endothelium, fibrin in the AC, and stromal thinning and necrosis. The ASOCT, unlike a confocal microscopy, the pattern is not specific to any particular microorganism for most of the lesions, but it does help us to determine the depth of involvement, to monitor the course of the disease, and to titrate treatment. For example, this was a 24-year-old girl with fungal keratitis. LASIK was done somewhere outside, and she developed a minor trauma and developed this. And so we could comfortably measure her course over time, seeing that although the lesion was fairly deep, but at no point there was evidence of any thinning or a risk of perforation, which could be seen clinically also, but an ASOCT just helps to, monitor the resolution more easily. And in the end, she healed with a scar which was subepithelial, but the vision was maintained at 6/9, and so nothing further was done. In some cases, though, however, especially for retrocorneal plaques, it's been seen that the characteristics may indicate a broad etiology. For example, in fungal keratitis, the borders of the plaque have shown to be irregular, whereas in a hepatic keratouveitis, very clear demarcation has been shown. Now, these are not 100%, but these are suggestive. And so this was one of our cases, the two pictures on the left. He was a diabetic, a fulminant kind of a keratitis which was not responding to fortified antibiotics. The scrapings were not coming positive. The PCR was not showing any results. Not responding to fortified antibiotics. So as the patient was not responding and he had keratic precipitates at the back of the cornea, we just tried to have a closer look at the OCT. And this seemed to resemble the picture on top, clear borders, and which is why then we went ahead and gave antivirals, oral antivirals, and after a few days, oral steroids, and there was a remarkable improvement. This is a 70-year-old male referred with post-op non-resolving corneal edema 1 month after phacoemulsification. And this is where I would like to highlight the role of a swept source OCT. So there was only corneal edema, no DMD detected on a spectralis. But if you do a swept source OCT which has a greater depth of penetration, one could nicely see that there was a Descemet membrane detachment which was there in the periphery, and the center was probably missing. And so a post-C3F8 injection, the patient cleared up. In the periphery, we could see with the spectralis also the DMD, but the resolution was much less, much better with the spectralis. ASOCT can also be used in keratoplasties, for example, to monitor the graft thickness in these cases of corneal rejection. As the graft thickness goes down, we know that the rejection is improving, the corneal graft. This is a case with bilateral granular dystrophy. The depth of the OCT helps us to plan the surgery. This was 200 micron depth. We planned the ALTK with a 200 micron head, using the 250 micron head because that's what we have available. And once it was planned intraoperatively, one could see the thickness of the graft which was there. And we could see that this was approximately a 1/3 graft thickness which we got, the button. And then it helped us to monitor post-operatively also how the graft thickness gradually came down over a period of 10 days. The same for managing a recurrent case where we had a superficial recurrence, and this could be managed with a PTK. Similarly, for endothelial keratoplasties, I'll just take a few seconds more. I'll run through this video. We can monitor the attachment of the DSEC lenticule, and we can monitor how the graft is improving over time, the thickness improving and the clinical picture improving. So to conclude, the swept source OCT provides a greater depth of penetration and a larger field of view. Visualization of lenticular pathologies has dramatically changed, and if available, it should become a part of our routine workup for some special situations in cataract. Purely corneal pathologies, spectral domain OCT has an edge because of better resolution. Thank you for your patient hearing.
Thank you, Dr. Chintan. I think that was a wonderful display of the third eye for a cornea specialist. I would like to call anterior segment OCT because it goes beyond sometimes what we can see. Any questions for Dr. Chintan on its use in cataracts? I mean, I think it's summed up so well. Especially, I would say patients who have undergone intravitreal injections. They are the very nasty cataracts, and they show such a surprise on the table. I think it's a must for each and every case. And you should do, and especially in case of ocular surface tumors, lymphomas. I mean, although Dr. Chintan touched about it, we have patients of like benign lymphoid hyperplasia, or it is a lymphoma, and how they need to be investigated, some hemogram or some detailed blood investigations. And that can actually, although it has doesn't have a very high level of correlation with systemic lymphomas, it is there, but and usually it is not a life-threatening thing. But it does make so much of a difference than just letting a red patch go. We do see these salmon patches, and ever since we started looking for them, we are diagnosing them more and more.
That's true.
I don't think we ever diagnosed lymphomas till we got the ASOCT actually.
Yeah.
And also, and now we have several patients in our practice we have diagnosed as with the salmon patch lymphomas and benign lymphohyperplasia. Any questions from the panel? And Dr.
Just
Basak, is there any
one
comments or
comment I'd
questions?
like to make.
Yeah.
Yeah.
Excuse me.
Very nice.
Thank you, sir.
Those pictures actually, really this ASOCT actually makes our life easy. So what we follow that beautiful pictures and all images are so valuable for the corneal surgeons.
Sir, voice little closer.
For the corneal surgeons, especially it is for endothelial keratoplasty. Sometimes that when you get the referral from the peripheral colleagues, the Shamurda do a DMAC or DSEC. So, but sometimes you cannot pick up in slit lamp because cornea is so
Yes.
thick and it matters. And there if you have a good OCT in your hand and you surprise that there is DMD.
Yeah.
So life is easy, so explain the patient. That is also for counseling of the patient. These are very, very important. That, okay, so guard your colleagues that I will give a try. Probably you will not require a keratoplasty. So I'll give a try. Sometimes they come late, so it matters. One injection might fail, then you have to give. So serial OCT on different post-op days after injection is very much important. So in my practice actually what I do OCT prior to my surgery or all PPK cases. All PPK. This is for many reasons. One is to see any DMDs or DMD is, it is there, it is intact DMD or the surgeon has eaten away some of the area.
Yeah.
Desmet. Second thing, to measure the corneal thickness also. At the same time, it gives the corneal thickness. And I also take the other IOCT, normal eye, to explain the patient what is wrong in your this eye. Sometimes they cannot understand. So your thickness in this eye, say 500, is 700. So we'll make it happy. So it is for counseling, for our own understanding, and post-operative, of course, I see my patient on, DMAC patient on, not on day 1, rather on day 2 of surgery. Day 1 still some air or gash is there. Day 2 it is like 3/5 gone. So you could detect the detachment, early detachment on day 2 or day 3. So you see, and again explain to the patient that these are then we have formula like 1/3 detachment or more than
Yeah.
1/3, then you give a, like you observe the patient or immediately you take the patient to OR and give again injection. So it makes our life easy, and as you rightly said that in microbial keratitis, we do in all cases of microbial keratitis, both ASOCT and anterior segment photography. This is also for counseling of the patient, not for our understanding. Counseling of the patient is very much, and we always do in both the eyes. What is normal they should know,
Yeah.
and then what is abnormal in that particular eye. And sometimes you see plaque, and that your change in diagnosis. Sometimes you see severe necrotic zone, probably you are thinking it might perforate. So this sort of lot of things and help actually, even for that case that if you want to give intrastromal injection, your OCT also tells you that what is the surrounding healthy area. Because we try to avoid the necrotic area, then there may be disaster. So we give like that way.
Even for like keratoconus, I didn't touch upon the depth of
Yeah.
scars, how much
Ke-
desmet is
keratoconus
involved. Yeah,
again
yeah.
another area.
Yeah.
So that way, if you have full, like you showed, we we have Solix and other that gives full anterior segment up to the posterior capsule of the lens. So that, as you said, rightly said, the PPC and all these things, lens fluidics, everything. So you can easily, and you can measure them. That is the best part, like halting of the ICL. You can actually measure them. Wonderful.
Well,
Thank
thank
you,
you,
sir.
sir. And